Without further ado, I'll introduce Dr. Kordus. Dr. Natasha Kordus got her Ph.D. from Gallaudet University. She has extensive experience as a psychologist in both the school and private practice settings, and she is currently working with Collaborative Psychology Group, and her area of expertise is in assessments. And she has a tremendous experience working with our deaf, especially our DeafPlus population. So without further delay, here is Dr. Kordus.
Okay, hello everyone. I am so excited to be here today. So, some of you, oh, there goes the PowerPoint. Okay. First off, I would like to begin explaining a little bit about my envision for today's presentation. There are so many different issues to cover with this topic here. I'm going to try and touch on everything. It is difficult. I also want to make sure that I satisfy your needs and really touch on any questions that you may have. So I want to encourage all of you, if you do have any questions, please go ahead and take advantage of raising your hand. On Zoom, you can press raise hand if you have a question that you'd like to address, or if you feel more comfortable typing it in the chat box. Kristen will help read those questions off so we don't overlook anything. First, I want to inform all of you that we will be having intermittent breaks for questions. Next slide, please. Okay. What I have prepared to discuss today, this is a large agenda. There are 5 things that I would like to cover, 5 different areas. I would like to talk about the difference between diagnosis and eligibility. I would also like to talk about mental health services, talking about the difference between behavioral intervention and mental health intervention. We will also be talking about accessing regional centers. And if possible, try to discuss what parents can do at home. All right, so those 5 topics we're going to touch on for today. Next slide. You may already remember Kristen having a workshop recently talking about access for special education. The difference between diagnosis and eligibility. I just want to review this very briefly, this topic again. Diagnosis means it's what a psychologist observes. They use the name DSM, diagnostic, and the statistics manual. DSM has over 260 different diagnoses. And we compare that with different criteria. also observing the children, seeing how their symptoms are and what their behavior looks like, observing their data, looking at parents' information that they provided, the school's information that they have provided, and the information that we have personally gathered and what we have seen and observed in that assessment process. We collect all that information and we decide what a diagnosis is based on all of that data and how severe the symptoms are. We do recognize that some diagnoses are developing. It's developmental, meaning from birth till death, they will have that permanent diagnosis. So for example, when a child has a diagnosis with autism or ADHD or CP, those diagnoses are considered as developmental diagnosis. Those are permanent diagnoses. They will have that forever. That will follow them forever in their life. It just depends on how severe their symptoms are. They can reduce over time, but the diagnosis itself will stay. Another criteria in DSM is like anxiety or depression, etc., are not considered as developmental. Those can mitigate with time, and that diagnosis can come up later in life. So those two things are very different diagnoses. And I'll explain in more great detail later. Eligibility is really how a children that have symptoms that interfere with the ability to progress in school. For those symptoms that are assessed by the school psychologist, and that information is brought to the IEP, the IET team. And they will have a discussion about if their children are progressing or how they're doing in school. Based on that, they will come to a decision if they're eligible to have an IEP. Does that make sense? Sorry, it went a little off point here. I can't see Kristen. Okay. I'm not going to worry about that. Thank you. That's better. I can see you. Yes, I feel like I'm talking to myself. It's nice to have an audience. It's hard for me to just be the only one on the screen, so thank you for joining me. Anyways. It's just because the children have a diagnosis doesn't mean it's automatically that they're going to qualify for an IEP. Children need to have and be shown that they're progressing in school and that they're not meeting their milestones, and so they will decide to provide an IEP. That is the difference between diagnosis and eligibility. It's really fascinating for me. Lately, I've been noticing a lot more referrals here in my private practice where, the schools have actually told parents, oh, no, you need to have a diagnostic first before you access anything and before they will give them an assessment for the student. And so I'm shocked, to be honest with you, because it's wrong. I want to let you guys know that that is wrong. When parents suspect or have concerns and request an assessment by their school, the school has a responsibility to fulfill that request because it's free and they're required to do it. They are required to give you an assessment plan within 15 days. And so really there should be no excuse there. The schools are required to do that. Mind you, the school can do the assessment and have their IEP team meet and say, no, your child is fine. They don't need an IEP. They don't need services. And then you can disagree and request an IEE. And then you can go out of the school and the school has to pay for an independent evaluation. And then you can go out and have another independent contractor give you the diagnosis. I can explain that process if you guys want. Really, if any school says no to an evaluation the first time that you request for one, that is wrong. Anyways, I won't indulge with that. Kristen has already touched on that topic. So we'll move on. There are actual 13 different categories for eligibility. Again, comparing to 260 diagnostics categories in DSM, those two things are very different. So that's the first topic that I'd like to touch on. Moving on to the next one. Access to services. Okay. Oh, next slide. I apologize, I jumped ahead of myself. Oh, there is one more thing. I'm happy you brought that up. When you have a psychologist or a medical professional doing a diagnosis, they can provide a recommendation and a treatment plan if they're needing ongoing treatment with your child. And so that's a big difference. And I'll touch more on that topic next in regards to mental health services. The diagnostics is paid. How? It's privately paid or through insurance. The school psychologist can't diagnose a child. That is not within their expertise and their licensing in the state of California. Only a clinician and a psychiatrist are allowed to do that. I am licensed in the state of California to do so. Eligibility. It's decided by the school psychologist to provide information, data, to the IEP team. They are only focusing on the 13 categories and using all the data included from the school, some information from parents at home, making those comparisons, and that is free. These are the potential services that are available to you. Okay. So one thing I would like to mention, now that we're on this topic, the IEP team can decide that these services available can be provided to the student. If there's an outside private psychologist that recommends these services and they accept those services and say that the child needs these services, they will accept that. They will give those services. So a private psychologist like myself don't really have the power within schools to force them to provide these services, but we can strongly recommend. Okay, next slide. Accessing services. There are multiple agencies that can provide services. Of course, there's regional center, there's private therapists, there are occupational therapy and clinics, PT, speech, a variety of different services, and they vary by department and county. It's complicated. Unfortunately, it's not standard. It's really not. That's the unfortunate part.
Okay. So this is where I want to go into depth. Counseling services in schools, they can vary a little bit, but generally, they tend to be 30 minutes in length. They tend to be pulled out for these services. They tend to pull the student out of class. The school counselor, or sometimes the school psychologist, will do one-on-one meetings with the student, and they tend to focus on what issues may be a barrier in the process of learning. So if students, they're not focused in class, or for example, they have a problem with making friends, then the counselor may discuss how to improve on those certain topics and chat with them, or maybe say chat with friends and try to resolve these problems. Or they would ask how we can use friendly touch. So what is friendly touch? Maybe trying to get their attention and then having a conversation with them. Often, if your child is in a mainstream setting program, someone who's really skilled with deaf in general. And oftentimes that there's it's kind of awkward to have an interpreter placed in and they do the assessment. They try to figure out if their issues are really affecting them or if it's emotional, if it's behavioral. So I want to hold that for a minute, hold that topic. Now for deaf children, if there's any concern that their issues are more in depth, maybe when it comes to mental health, then an IEP team maybe refers called an education related for mental health services. So I want you to understand, it's an ERMS. It includes outside private therapy. It can also include placement in NPS schools or a non-public school so they can focus on the issues that they need help with. Unfortunately, where they have deaf knowledge, they don't have much deaf knowledge. And so for deaf children's services are called. So we maybe placed with an interpreter.
Can we switch interpreters? I think we lost audio on the other interpreter.
Can you hear me now?
Yes, thank you.
Okay, perfect. So now I want to back up a little bit. I know oftentimes we hear that parents with children who are identified as DeafPlus, often their children are referred to what's called as a functional behavior assessment, and then the results are BIP. So my brain, there's 15 different categories, so bear with me. First, I want you to understand that the BIP, Behavioral Intervention Plan, the purpose is to teach the teacher how to support and help the student. So the idea is to give the teacher a guide, a list of resources on how to provide a positive reinforcement for that child and to shape that behavior, to change any negative and become a positive behavior. Is that understood? So oftentimes a teacher will realize that facial expressions or a body movement or them saying a certain thing is actually reinforcing their behaviors. So that's the heart of BIP. That's how it was designed a long time ago, historically. So that's one concept to hold, to keep in mind. Another concept that I want you guys to understand as well is that with
reauthorization for IDEA in 2004. There it is. That's the slide. Thank you. Thank you so much. The person doing the slides understands me so much. So the idea is that with RTI, a student will have all of the assessments be assessed through everything early on, and then provided intervention early, so that any early behavioral issue can be nipped in the bud. And then we won't have those behavioral issues then happen in class as they get older. So the idea, that concept, it's good. It's pretty cool. So there are two really significant foundational beliefs in RTI. The first is that all over the entire school has the effective tools for assessment and intervention. Okay? And the second belief is that all behavior is communication and of emotions. So those are the two beliefs. Okay? What's my next slide? The next slide, which one is it? Okay, so I forgot about which slides for next. Okay, so the first, when I talked about the two beliefs, the idea that PBIS is that if I provide intervention at the first level, and routinely, all intervention, all assessments, all cultural sensitivity, cultural responsive, it will be best for behavioral issues. The goal is 75 to 85% of all behavioral issues to be reduced and have no more problems, okay? So that concept is pretty cool. The problem is, yes and no. So if we look at the facts, and I'm experienced, I've worked in schools before. When the school looks up to the state and they say, okay, what's the assessment tools? What assessment tools do we have for deaf? And for DeafPlus individuals, the state says, well, I don't know. And when the school psychologist says, we need standardized, we need this verified, we need the proof that these are good assessment tools. We ask Gallaudet, we ask RIT, we ask research centers, we've asked all over and nobody knows. Because of course, we set up the state standard before we did measures that were available. Additionally, since RTI in 2004 was set up, hearing students have been assessed in different areas. In just many different areas to look at their academic progression, to make sure we can identify, okay, maybe they're not making good progression or anything else that may be happening. A MAP, it's called the Measure of Academic Progression or Progress. That itself assesses the tools from Washington State. That's one that looks at the academic progression in for deaf students. But again, academic doesn't really mean behavioral. So what do we do for behavioral? How do we know what's really effective for behavioral intervention? And do we have our standardized for behavioral intervention for deaf and students? Or is it universal or intervention for DeafPlus? What about that? We don't have anything. There's nothing. So schools, by each school all around has to function like independently and try their best to figure out what to do. And I wanted to let you know that California Schools for the Deaf here, I have been in contact with them often. And they do try to collaborate with each other, but standardizing and preparing, that has not happened yet. So the next slide. So behaviorals as communication of emotions. So this is really important. And it's very complex at the same time. Psychology as a concept, I think, so both children and adults, behavioral is really a reflection of our emotions. If we teach children how to manage their behaviors, we are teaching them how to manage their symptoms. Okay? So I want to repeat that. If we assume behavior is an expression of their emotions, then behaviors are symptoms. If we're teaching children to manage their behaviors, then you're teaching them to manage their symptoms. So this is the same for adults as well. If I'm trying to, for example, manage my temper as an adult, and I'm an adult, I'm learning not to scream or have conflicts with people. I'm learning to suppress that emotion, right? It's the same with children. If I'm mad and I need to learn how to calm down and not scream, right? However, if you stop with just, oh, okay, stop screaming, and you tell that child to stop screaming and they assume that's it, I've told you to stop, that's just managing. That's not good enough. And that's the mistake here. Because that's just the surface level. There's more in-depth involved. There's more involved.
And so behavior intervention, I think what happens often with DeafPlus oftentimes what people don't realize is if you're sad or feeling happy or confused, nervous, children will express that in their behaviors. If you are depressed, manic, disoriented, anxious, feeling serious, children will express that in their behaviors. What's the difference? For a psychologist, they can recognize that. They notice those things. When they're sad, happy, confused, nervous, it's temporary. It's very brief. It's for a brief time. The symptoms are not permanent. They don't happen in school and at home and at church and all day and for long periods of time. They're not sad for weeks on end. They're not happy, so happy they can't sleep for days. They're not so nervous that they can't focus or that they can't get out of the car when it's time to go to school, or they can't interact in social settings with people that they were able to interact with a month ago. And so that doesn't go on for months to where they refuse to socialize because they're so nervous or their anxiety causes them to hide. That's questionable behavior. When children start to display problems where they can't sleep for weeks on end, or they're sleeping too much, or they're disoriented, because they may be reacting to things that you can't see. Maybe a child is so anxious and they weren't, a month or two ago, and they were just fine. They were displaying normal behaviors. And so when their behaviors become concerning, that's when a psychologist will say, this becomes a diagnosis. I do understand why it's complicated for parents, for the school staff to say, no, it's just behaviors. There's nothing more to it. If you cut the behaviors, then, everything will be good enough. Reason is, DeafPlus have many different issues that are involved. Reason is, oftentimes they have a delay. They have an issue that can impact their development. If it's a cognitive solving issue, if it's a theory of mental, meaning that their ability to look at different sides, put themselves in different shoes. Oftentimes there's language deprivation. There is academic deprivation. There are various different things that can impact a child. And so we need to figure out how we can separate those layers and figure out what is mental health, what is deprivation, and what is their medical or developmental issues. It's a lot to consider. It's tough. Or, there's trauma. Oftentimes, DeafPlus go through multiple different types of medications and procedures, and they are placed in the hospital, and that causes them to feel trauma. And when children are in the hospital in that period of time, all of their developmental growing is put on hold. Their academic exposure is put on hold. Their language development is put on hold, because oftentimes it's only the parents that are there signing, and they can't be there all day. So it's short amount of time that they're exposed to. You know, those are the things that impact a child. You know, trying to figure out everything that overlaps. Also, how to provide intervention. A lot of mental health professionals are unsure on how to discuss feelings. So therefore, they don't include themselves in those discussions. Really, there are ways to interact with them. There are play therapy. There's different ways to progress with children. Mainly, children do not say, you know, I'm experiencing a lot of essential angst. They don't do that. Mainly, children will play, and that's when they express themselves in a playful manner in their behaviors, in their, territory, what they're drawing, things like that. You know, playing with sand. DeafPlus is no different. So it is very possible to observe a pattern in their behavior and make a diagnosis based on that for DeafPlus. To observe their behavior, also consider their mental health as an overlapping issue in regards to being angry, you know? And also understanding that from the beginning, understanding that depression, anxiety, all those different emotions are temporary, and they can pop up, disappear, pop up, back again. It's not from birth, like CP, autism. Those things are diagnosed at birth. And so those symptoms will continue to display. Of course, they can mitigate with intervention. Maybe someone's experiencing a lot of depression because they've experienced a lot of downfalls in life, going to the hospital, being displaced to a variety of different schools, and that can lead to a person feeling depressed. And that happens later in life, 12, 16, 18. Those things can happen, but with intervention, they can mitigate those symptoms. They can resolve. Okay, so how are we doing on time, Kristen? Should we have a break for questions? We have about 30 minutes. If you want to wait, save the Q&A for the end of the presentation in 20 minutes. Then we can open it up for Q&A. Okay. Let's jump to accessing the regional center. Awesome. So the regional center. I would like to explain two different things. I don't know how many parents have already accessed regional center here. I know it's a process and it varies depending on where you reside. Some regional centers are awesome, some are questionable. It takes a while. And so, you send in your application, you meet with the case manager. The case manager will ask a variety of different social questions. They will do the assessment and also provide background information. It's not really an assessment per se. It's more of just questioning about the child's background, collecting data. And then they will send those referrals to a psychologist. And hopefully that psychologist, like myself, signs and is influent in deaf culture and DeafPlus and can properly evaluate a child. My job as a vendor for the regional center is to do evaluations for deaf students here in Riverside. And our job mainly is to confirm or diagnose children with autism or IDD, intellectual development disorder. Us as psychologists don't confirm CP or seizures or other category, medical category. It's considered fifth category. That is considered medical. So we only diagnose autism or IDD. Those two things are what we diagnose for. Next slide. Before we jump into the next subject, we will send the report to Regional Center. Their team will determine eligibility. The psychologist's job is not to determine eligibility. My job is to determine the diagnosis. That's it. And so I really want to emphasize that. There are two common questions that I often get asked from parents when they come. One of those questions is, oftentimes parents will come and, for example, they'll have a child who is 2, receiving early intervention, IFSP, with the regional center providing services, and was dropped. They did not get an IEP. They are not receiving any services, but they still have a diagnosis. And the parents are puzzled on why they're not receiving services from regional center. The regional center with schools have a criteria for determining the need for services. The regional center, by law, it's called the Lanternman Act. Lanternman Act. They follow those criteria. They make the determination that their services are for most severe symptom kids. If the child has a language barrier and it's very severe, they will provide services. If it's severe, which means 2 standard deviations below the standard, means below the average. For other children who have disabilities. For example, they'll compare your child to another child who has a disability. because the regional center want to serve those children. Oh, hold on. No, we're skipping ahead. Okay, perfect. The regional center only can serve those children that feel overwhelmed academically and they can't serve. And that is the reason why regional centers may turn down your child. To be honest with you, when I worked at schools, I felt the same. I was confused on, this child is autistic. Why did regional center not provide services? Well, the regional center said, well, their symptoms are not severe enough, which means the regional center is basically saying the school is responsible to serve this child. The other question, the common question that I receive from parents is, I noticed that my child has a diagnosis with the provisional. And what does that mean? Provisional means the psychologist is unsure if that's what's going on with the child. It can happen. When a child has symptoms of autism, but maybe don't have all the symptoms. So there are 3 categories, really. Repetitive behavior. It's ritual behavior. Like hand flapping, bobbing, walking back and forth, pacing, those things, those symptoms. Language delay. Social delay. They prefer to isolate. They don't prefer to make eye contact and such. Those 3 categories. For example, if I see a child and maybe they only have one of those symptoms, they're only displaying one. It's only language delay. And, moms told us that she used to be very isolating. And yes, for a while, they were hand flapping, but they stopped that. And so they're better socially since they have gone to school, but they still do have language delay. They may be deaf, but that's about it. I think that's why. Well, what do you do? Will you give them a provisional? And they will meet with a team to reevaluate for the next year or 3 years. And they may remove that. During the 3 years, they would provide a lot of language intervention to see if the child is progressing and look at their behaviors. Does that make sense?
So that's what it means when you get a provisional diagnosis. Person saying, thank you, thank you. Any questions now? You can go ahead and use the chat box if you'd like to ask questions. So the first question, if you're ready for it, the first question is, do regional centers only provide services up to the age of 3? No. Regional centers are supposed to give services for life. So regional centers, they want you to identify children who have developmental, meaning any condition from birth. So again, that means autism, ADHD, seizures, or other cerebral palsy, things that are severe from birth. Those conditions. From 0 to 3, they will provide you early intervention, an IFSP, coordinated with those kinds of services, and they'll provide you services in home. At the age of 3, they will reevaluate and then decide if they're ready for an IEP, and then transition into an IEP. And then they will continue with that IEP until they're 22. After the age of 22, regional centers can still provide services like housing, job training, variety of different resources. So it really depends on the regional center where you are. So in another county, in Kings County, I'm not sure what's available in that area. The regional center is there in that area. So it really depends on the age as well. Maybe NorCal can get people from a regional center to come and do a presentation as well. Is it okay if I clarify, says Kristen? Go ahead. So normally, from birth until 3 years old, the early intervention is in the home, is where you'll get those services. So for kids that have 25% delays, there's more areas of development that are needed. So 25% delay. So that's after 3. So there's a difference. After 3 years old, then those categories of autism, cerebral palsy, epilepsy, intellectual disabilities, and then a 5th category that's separate, medical conditions, means that you have severe disability in 3 or more of those categories. In 3 or more of those major life activities. So speech, communication, expressing, receptive, expressing communication, receiving communication, everyday life activities, how to take care of themselves. They can, when they're taking care of like financial, budgeting. It can be if they're not life independent. So it could be many things, but it's important that it's those life activities are severely impacted. I just want to make that very clear. And Natasha said, if you don't mind, if I thank you for expanding. That was a much better definition than I gave. So very perfect. Thank you so much. And then there's another question in the chat box, says Kristen, a really good question. So is it acceptable for schools to treat autism and language deprivation as the same? I'm not sure what you mean by treat them as the same. because they're not the same. Can you explain? Not provide services? Okay. Oh, well. Okay. Okay. Chris is saying 5 minutes. So Natasha's saying they have to provide services. Sorry, Chris is saying 15 minutes. 15 minutes left. So Natasha's saying, really, they have to provide services for both. I mean, it seems really both want to really both identify, and then what you need to identify what areas of need both need. Autism children have, for example, they want to know, again, going back to those three identifiers of autism: expression, repetitive behaviors. We know that children who have autism stem a lot. It's a trigger, it's a stemming. It's a coping mechanism. So can we shape that behavior and do it appropriately? Or can we shape for a specific time and during the day, or an area that they can go ahead and stem? Or do they need ABA services for a while or later on? When are they doing it? Is it severe, or is it very little? It doesn't happen often. Is it impacting their essential functions? Is it do they express this when they're stressed out? So that's one category. The other category, again, is language. Kids who are hard of hearing or deaf, profoundly deaf, their language is in sign. And providing interpreters in class, that's a completely different story. But how I feel for interpreters in class, especially with DeafPlus students, it's frustrating. And often, because DeafPlus, they're not looking at the interpreter in the front in class, and then they need a signing aid, and then other words for frustrated. And hold on, I believe I see another chat box. I hate when a school says we don't have services, period, and that's it. Too bad. Oh, that really makes me mad. That's where Kristen said that's against the law. Exactly. When they say period, no services, parents, I'm so sorry. We have to continue to keep fighting and get lawyers and get advocates and really make noise, scream, because the schools will just shrug their shoulders and say, sorry, we don't have it. Oh, okay, sorry. And that is so frustrating. Exactly. Another person tapped in the chat box. Interpreters through Zoom. Exactly. They're not great interpreters. So
it's not appropriate.
Yeah, exactly. It's not. Like, come on. And really, it really grinds my gears. I feel like we need to have a regional programs all over California, all over, just small programs. Like, we have the university and we have small programs all over California. And I love the Deaf Institute, the California School for the Deaf. And there's plenty of deaf kids in California. And we should have regional programs all over, especially for DeafPlus and deaf all over. Because right now we have so many mainstream schools, and the districts need to do something about it. And the only way they'll be forced to do it is if parents scream, if they make noise. That's the only way.
Yeah.
Treat autism and language deprivation as the same. Wow, I am so sorry. That is ridiculous.
You could request for an IEE.
Oh, yes, I agree. Really, request for an IEE. This is serious. Yes, I would do that. I would request an IEE. This is awful. So oftentimes parents, oh, another chat. So again, an IEE, independent educational evaluation. It's separate from an IEP. An IEP is a legal document that lists all of the services and agreements that everyone has gone from the school. An IEE is an evaluation. That's it. The school, however, is required to pay for that IEE at least once every year. So that's, take from it what you will. So tell the school that you disagree with your school psychologist's findings and that you want an IEE. Then you can tell that person what their findings are, or you can find a person, either you or the school can find a person to do the evaluation. And then the school district has to pay for that IEE. And then you can present, you can take your child and in person, they do those evaluations, and then they'll list out the criteria and you can hand that in. Yes, Kristen?
I do want to mention that technically you could request for an IEE. If it's been approved, they will pay for a one-time fee.
Right. I forgot about that.
Meaning they have to go.
Yeah, that's right.
Doesn't happen often, but it can.
Exactly.
I just wanted to mention that little snippet.
That is right. That is, wow. Must be, oh, and then repeat again. The interpreter's voice was lost. So if a parent requests an IEE, meaning independent educational evaluation, and you disagree with the school district's evaluation, you can request a different person, not the worker for the school district, to evaluate your child again. So the school you have two choices. The school can approve and decide who to evaluate your child, or you can request to assign. You can file against it. The school can file against the parents. Yes. So why do you have to explain the decision? Why they didn't recommend eligibility, or why they decided specifically that they didn't qualify or they weren't eligible, whatever their reasoning is, why they disagree. Is that clear? Did we lose the interpreter again? Did you guys hear that? Okay, perfect. Okay. Okay, perfect. Okay, now we have 5 minutes left. Okay, so I sent my PowerPoint and then several resources as well to NorCal for parents because there's many things that we did not cover today. So you can look over that PowerPoint and all of the handouts that I have available ready for you guys. Also, it has my contact information. So if you want to follow up with questions or anything, you can go ahead and contact me. My office is in Riverside, California. And I really appreciate this opportunity. It was really fun. It was really nice to interact with everyone.
Thank you so much, Natasha. I appreciate your time.